Welcome to everybody coming on to the what's the 6th Anne Klibanski Visiting Lecture Series. My name is Steve Greenberg. I'm the director of the Office for Senior Faculty Affairs in the Center for Faculty Development, and this series is under the umbrella of the Center for Faculty Development. Today's session, Dr. Chu-Chun Huang, who will introduce in a moment from National Taiwan University Hospital, will present insights in the pathophysiology and treatment of polycystic ovary disease. So just a little bit of an introduction, very briefly, to the Anne Klibanski Visiting Scholar Program. Was created by former CFD Director Miriam Bradilla to offer Mass General Hospital women faculty the opportunity to serve as a virtual visiting professor and give grand rounds at other national or international universities or institutions, and all this would be organized by a champion who's typically a senior faculty member at MGH or part of the Center for Faculty Development. For people here at Mass General, I don't have to tell you the program's named for Anne Klibanski, who's now the present CEO of the Mass General Brigham, former director of the Center for Faculty Development, and a tremendous researcher, tremendous mentor, tremendous champion for women faculty, and a role model for countless numbers of people, certainly including me. Here, I'm just going to show over the next few slides, just very briefly, pictures of the series of the cohorts of Anne Klibanski Scholars. And I, needless to say, I won't be able to name them at all, but I'll just go through the slides. And each of the applicants went through a competitive process to be named an Anne Klibanski Scholar and to be able to give awards as the second class of 2021, 2022, 2022, 2023, and the current 2023 and 2024. And here the champions, and again, it's the champions' role to help connect the Anne Klibanski Scholar with the national and international institution. And Dr. Jan Schifrin, who's highlighted here, is one of the champions, has been the champion for this Anne Klibanski Scholar. Will be introducing today's speaker. This was the return visit for Dr. Erin Bradley, who's also on the call, who was one of this year's AK Scholar winners. And just to summarize again, the goal is to support and advance the careers of women at Mass General and throughout the U.S. and abroad. We look forward to further applications, because I think this has been a very successful program, both for the early career women faculty who've been the recipients, and also just for creating new collaborations. And these are institutions that have been part of it, and showing here in particular in the box the National Taiwan University Hospital logo in honor of Dr. Huang. So at this point, I'm very happy to turn over the virtual microphone to Dr. Schifrin to introduce today's speaker. Jan, please go ahead.
Thanks so much, and agree. It's really a spectacular program and a wonderful way both to advance the careers of women faculty, but also to build these terrific connections between Mass General and wonderful international institutions, including, of course, the National Taiwan University Hospital. So really a pleasure to introduce Dr. Chu-Chun Huang. She is an assistant professor and also the chairman of the Department of Obstetrics and Gynecology at the National Taiwan University Hospital Yunlin branch. She's a reproductive endocrinologist with a PhD from the National Taiwan University. Her principal research interests include fertility preservation and polycystic ovarian syndrome, or PCOS. This includes the application of induced pluripotent stem cells as a disease modeling tool for PCOS. Really excited about hearing this research today. She presented her work in the annual Congress of the American Society of Reproductive Medicine in 2014, 2019, 2022, and 2023. She's also the current Secretary General of the Taiwanese Society for Reproductive Medicine. So again, a very warm welcome for Dr. Chu-Chun Huang, who is joining us at midnight in Taiwan. Thanks so much, Chu-Chun.
Thank you so much for the kind introduction. Thank you, Professor Schifrin. We have communicated several times by email, and thank you for Professor Greenberg. Thank you for a kind introduction for this programs. I feel really honored to have the chance to be a part of these programs. And today I'm gonna share some research results from regarding to the pathophysiology and treatment of PCOS. That's what we have done in previous decade. Okay, so my CV has been introduced, and I have nothing to declare. So here's some learning objectives. I'll go through a little bit about the background of PCOS, and I'd like to mention some new diagnostic algorithm just updated last year. And I would like to share some results from our studies using induced pluripotent stem cells as a disease modeling tool, and also some treatments that we have done in the past. Okay, so we know PCOS is a very common disease. It is actually the most common endocrine disorders. It affects up to 10% women, not only in the United States, but also, I guess, all over the world. So approximately 5 million women in the United States might be affected, and many of them may be underdiagnosed, undiagnosed. So it's really important that we need to really take care of these patients. And actually, PCOS, polycystic ovarian syndrome, this is first recognized by these two also excellent obstetric and gynecology doctors in Chicago, Dr. Stan and Dr. Leventhal. They first published this paper in American Journal of Obstetrics and Gynecology in 1935, around 19 years ago. They described 7 women, and they have they all have irregular cycles, hirsutism, and obese. At that time, they did the surgery for them. They did wedge resection. They cut a piece of their ovaries, and they found they have polycystic morphology. And after treatment, after surgery, these women can recover their menstruation and even got pregnant by surgery. So they are really the pioneer in the diagnosis and treatment for this syndrome. So this was called Sting-Leventhal syndrome during 1930s to 1950s. Well, actually, this disease might exist for a very long time, even more than 2,000 years ago, during the times of Hippocrates, that he had written in his work, Disease of Women. He said that some women whose menstruation is very little, less than 3 days, they look strong and healthy, and some of them looks a little bit like men, masculine. And interestingly, he also described about their fertility problems. They don't get pregnant. So that's really very early statement about this syndrome, very ancient disease. So we know there are thrifty genes hypothesis for metabolic syndromes, and PCOS is kind of a little bit similar to this hypothesis that we know PCOS phenotypes and genotypes might have some survival benefits during ancient period, that the nutrition is not enough, and so if the PCOS genotypes can save energy more efficiently, then this could provide some survival benefits. Of course, this is not a very good thing nowadays. And another survival benefit for PCOS is probably that we know pregnancy and delivery really has a high risk for women during ancient times. So if the women can give less births, having less children, this might give them also survival benefits. And so that's something interesting in the evolution aspects, perspectives of this disease. Of course, now we can diagnose these patients in a more scientific way. So if you're interested, you can check there's an updated guidelines, international evidence-based guideline for the assessment and management of PCOS. And that was established by many professional societies, SRM, American Society of Reproductive Medicine, and also European societies and many PCOS societies. Basically, regarding to the diagnosis, they still recommend to diagnose PCOS using revised Rotterdam criteria, which means the patients need to have at least 2 of the following 3 features, include chronic anovulation and hyperandrogenism. And another one is polycystic ovarian morphology. So that's basically the same with what we have done. But there's something new in this updated guidelines that it add first, for the first time, it add serum image level for the diagnosis of PCOS. In the past, we can only define PCO morphology based on ultrasound criteria, which means the follicular number need to more than 20, and also the volume need to, or the volume need to larger than 10 milliliter. But now, if we don't have ultrasound, then we can simply do the image, check the image level. So that's something new in this revised guideline. So here are some recommendations. Serum image level can be used to define PCO morphology in adult. And but we need to be careful that serum image level should be used in accordance with the algorithm. If the patients already have irregular cycles or hyperandrogenism, it is not really necessary to check image level. And another important thing is image level cannot be used as a single test to diagnose PCOS. The women still need to have other symptoms like irregular cycles or hyperandrogenism. So we cannot diagnose them simply based on a high image level. And one last thing is serum image level cannot be used to diagnose adolescent PCOS. Currently, adolescent PCOS can only be diagnosed by NIH criteria, which means the patients need to have both irregular cycles and hyperandrogenism. And image cannot be used to diagnose PCOS in kids because it has poor specificity in this age group. Okay, so there are already a lot of studies, a bunch of studies talking about how to apply image in the diagnosis for PCOS. And actually the sensitivity and specificity is quite similar with the ultrasound criteria. So now we can use image to replace the original ultrasound criteria. We can choose one, either one. And I think this really increased the convenience in the diagnosis of PCOS, that the general practitioners or endocrinologists, they don't need to refer patients to OB-GYN clinic to make the diagnosis now. Okay, so I guess some people might want to ask, so what is really the best image cutoff to define PCO morphology? I want to ask that. But actually the guideline tells us that each lab, there's no universally accepted cutoffs. Each lab should establish their own criteria, own assay-specific cutoff. So that's still a question, a problem for me. But still, I think we can check what other studies do. These are those 62 studies using image to detect PCO morphology. As we can see here, I think most of the study identify an image level between 4 to 6 nanogram per milliliter to provide the best area under curve to the diagnosis. And this probably equal to 28 to 42 picomole per liter. So I think maybe we can consider using that if we see patients with an MH level higher than 4 to 6 nanogram, maybe she can fulfill the criteria of PCO morphology. But I think there's still limitations in the diagnosis. We still need to establish age-specific cutoff and maybe assay-specific cutoff. Okay, so we just mentioned that PCOS can be diagnosed based on Rotterdam criteria, and Rotterdam criteria is constituted based on endocrine phenotypes. But actually, we know PCOS is much more than just an endocrine disease. The patients also have very high risks of metabolic symptoms. And actually, the patients, this is a chronological change in their presentations. During their adolescence, they have obvious hyperandrogenic symptoms like hirsutism, acne, and they also could have irregular cycles. They could have also childhood obese and also increased risk of depression and other psychological problems. And when they achieve adulthood, they still have very obvious hyperandrogenic symptoms, and they could have higher risks of infertility problems, 15-fold of infertility risk. And even if they get pregnant, they could have higher risks of pregnancy-related morbidities like gestational diabetes, hypertension, preterm birth. So this really causes a huge and lifelong health impact in these patients. And even until they reach menopause, they still have obvious increased risks of metabolic syndromes, cardiovascular risk, and even endometrial cancer. So these patients, this is really a huge health problem, and I think in all aspects of regions around the world. And we have tried to discover what is the potential endocrine risk factors related to the risk of metabolic syndromes in PCOS, because we just mentioned that these patients have very heterogeneous presentations, and we want to identify the potential risk factors. So we have published this. This is a retrospective cohort study, a cross-sectional study in 460 PCOS patients. We analyze the symptom patterns, and we try to classify these patients into different subgroups based on their phenotypes. And interesting, we found that there's indeed different prevalence of metabolic syndrome between different clusters. As we can see here, we can classify the patients into 4 clusters. And in those patients who have very high LH level and low free androgen index, these patients had a low risk of metabolic syndrome, only 7%. This is quite similar with general population. And for those women who have very high free androgen index and low LH level, and these women actually carry a very high prevalence of metabolic syndrome. So in this study, we've identified high androgen and low LH to be most related to the risk of metabolic aberrations. And we think this could probably help us to provide a more effective screening and treatment interventions. Okay, so I'd like to move to the pathophysiology. We know the pathophysiology of PCOS is really complex, and it is impossible to cover every aspect now. But if you're interested, you can check. There are many excellent reviews in Nature Reviews or Lancet talking about the pathophysiology. And I'm gonna just make a brief summary here. I think many people agree that PCOS is a multigenic disorder, just like diabetes or other metabolic disease. And it has a very high heritability in the twin study. It also shows strong interactions between the genetic factors, environmental factors, or epigenetic dysregulation. So yeah, a really complex interaction. Although the pathophysiology is not fully understood, but I think most researchers agree that androgens and insulin are the most critical factors in the disease mechanism. PCOS patients can have endogenous hypersecretion of androgen mainly from their ovary, and it has also been recognized as a neuroendocrine disease. These patients can have increased secretion of GnRH a neuron from GnRH neuron, and this can further increase the LH secretion from pituitary gland, and this can further enhance the androgen secretion. And also, the androgen secretion will cause the phenotypes of irregular cycles, ovulation dysfunction, and also other symptoms related to androgen. And another key problem is the insulin. PCOS patients are found to have dysfunction in insulin signaling pathway in many tissues, like muscles or adipocytes, and this could further impair the hyperinsulinemia, can also aggravate the androgen production from ovary, and also androgen can induce insulin secretion. So this is actually a really vicious cycle, and that's what we have known. But after so many years, PCOS pathophysiology is still not fully understood. And so that's why we started to use iPS cells in the PCOS research. And we think parts of the reason that it is difficult to be studied because there are limitations in the animal models in PCOS research. We know there are no naturally existed PCOS animals of the mice or monkeys. They're all artificially created. We give these animals lots of androgens and aromatase inhibitors, but that's actually quite different from human. Okay, so and some phenotypes are not that similar between animals and human, and yeah, so it is difficult to define these symptoms in lab animals. And another question is, PCOS is not treated by surgery, so it is a little bit difficult. There are limited accessibility to get patient cells or tissues. So that's why we start to use induced pluripotent stem cell as a disease modeling tool. As many of you may know that we collect somatic cells from the patients, like from our PCOS patients, and we can add the reprogramming factors and to make these cells reprogram to induce pluripotent stem cells. And then we can redifferentiate these stem cells into the desired cell types that we want to look at. That could be most related to the disease mechanisms, such as neuron cells. We just mentioned that this could be a neuroendocrine disease, and we also can differentiate these cells to ovarian cells. Okay, these PCOS patients have ovulation dysfunction, and we can characterize the disease phenotypes in these cells we differentiated, and to identify possible molecular targets for further treatment properly. And so that's what we have published in Fertility Sterility. We try to differentiate, we try to establish patient-specific iPS cells. We collect the skin fibroblasts from our PCOS patients, and we reprogram these cells into pluripotent stem cells. And we confirm their pluripotency by checking the related transcription factors like non-OCK4, they are specific for the stem cells. And we also check the pluripotency in vivo we inject the iPS cells into the SCID mice, and we confirmed that these cells can really differentiate it into different lineage, ectoderm, endoderm, or mesoderm. So after proving their purity, pluripotency, and then we can differentiate these cells into ovarian cells, ovarian granulosa cells. And we confirmed that our cells did express the granulosa cell specific markers. They can express aromatase genes and also FS receptor and MC receptor with quite high efficacy. And we just mentioned that PCOS is an epigenetic disorder and could involve some DNA methylation problem dysregulation. So we check the genome-wide DNA methylation array in our PCOS iPS-derived granulosa cells. And interestingly, we found there are indeed some differentially methylated regions, especially hypomethylated regions in PCOS group. Here, the yellow color means hypomethylated regions. And so that's something different between PCOS and control. And so we think this really gives more evidence for the epigenetic dysregulation, and especially in the ovarian granulosa cells in PCOS. And that's quite similar with the previous studies showing that PCOS patients can have DNA hypomethylation or hypermethylation. This could impair or dysregulate the gene expression involving many biological signaling pathway like hyperandrogenism, insulin resistance, or lipid metabolism. So this could further regulate the phenotypes, the expression of PCOS. And another thing we have done is we try to differentiate the iPS cells into vascular endothelial cells. We know endothelial cell dysfunction is a risk factor for cardiovascular disease. And there's some, not much, some evidence showing that PCOS might have certain markers for endothelial damage, and this might be related to its cardiovascular risk. But the research is not that much, and probably because it is kind of difficult to get endothelial cells in PCOS patients. So we try to differentiate our stem cells into endothelial cells. We've followed the protocols we found in literatures, and we do confirm that these cells are successfully differentiated into arterial endothelial cells. We see these cells can express very high proportion of vascular gene expression, CD31 and CD144. They're all markers for vascular endothelial cells. And we also check the lineage. These cells seem to belongs to artery, not vein or lymphatics, according to the gene expression. And we also do the single cell RNA sequencing, and we found there are differentially expressed genes between PCOS and control, like the figures showing here, that these differentially methylated expressed genes are enriched in several biological pathways, such as cell cycles, angiogenesis, and endothelium development. And we noticed there's a decreased cell proliferation ability in the PCOS group. So so far we think that this PCOS specific iPS self-derived endothelial cells, they really exhibit impaired cell proliferation, impaired angiogenesis, and that could provide some links to endothelial cell dysfunction and probably cardiovascular problems in PCOS. And currently, we're still working on how to differentiate these iPS cells into neuron cells. Like we just mentioned, PCOS is a neuroendocrine disease, and it is impossible to get neuron cells from PCOS patients. So we try to differentiate these stem cells into neuron cells, and hopefully we can have something interesting to share in the future. So the last part is the treatment of PCOS. We know the first line is always lifestyle, just like diabetes or other metabolic problems. Healthy eating or enough physical activity is the key and should be recommended to all PCOS patients. Of course, it's really easy to say and very difficult to do, but still we need to educate our patients that weight management is also very important. If they can lose 5% of weight, and they could have significant improvement in metabolism, reproduction, or even psychologically. And patients always ask me, is there any best diet for PCOS? Like Mediterranean or low carbohydrate or even intermittent fasting. I've tried intermittent fasting but failed because I ate too much during that precious 8 hours. So, well, the guideline recommended that there's actually no specific diet is the best. The key should be calorie restriction. If the patient needs to decrease 30% of calorie intake per day. So that's really the key. As for the composition of food, actually there's no significant difference between each type of the diet. And another important thing is to encourage them to do physical activity. And many patients also ask me, why can't I lose weight? I already did a lot of exercise, but if we ask them, it is kind of difficult to reach enough intensity of exercise. If they want to lose weight, you can see here, they need to do more than 300 minutes of moderate exercise and plus 2 times of weight training. That's equals to every day 1 hour exercise every day. So that's really difficult. It is really important to have a healthy diet pattern, not only do physical activities. Okay, so besides lifestyle intervention, we know for some phenotypes like chronic anovulation, irregular cycles, and hyperandrogenism, the first line treatment could be oral contraceptives for 6 months. If she has obvious hirsutism or hair loss or acne, oral contraceptives is the first choice. And of course, we need to check if she has contraindications according to the WHO guidelines. And the second line treatment could be drug combination. So here, for intractable hyperandrogenism, which means if the patient still have symptoms after 6 months of oral contraceptives, and we can try to add anti-androgen combined with oral contraceptives. And for those women, those patients who have high metabolic risk, we can try metformin treatment. Especially for those patients who are obese and have signs of glucose intolerance or insulin resistance, we can give them metformin treatment. And this can provide benefits in androgen or weight loss or their glucose insulin level. Although metformin is recommended to treat patients only with high metabolic risk, But in our hospital, we have tried to give this medication, give metformin to all PCOS patients, even though she has low metabolic risk. And interesting, we found metformin this has benefit in, I think no matter she has high metabolic risk or not, in obese PCOS patients or lean PCOS patients, they can have benefits after metformin treatment. We have published this in Journal of Clinical Endocrinology and Metabolism. After 24 months of metformin treatment, we can see improvements in many aspects. The patients can lose weight and can have lower androgen, can have lower insulin resistance level, and the benefits could appear in both normal weight or overweight patients. And another thing is the patients can resume ovulation by metformin treatment. Around 50% will have better menstruation after metformin treatment. So we want to ask another question is, can we predict the treatment response, therapeutic response by metformin for resuming ovulation? I think this is a kind of biomarker search or precision medicine. And we know, we think about circulating microRNAs. We know microRNAs can be a biomarker for many diseases to diagnose or predict prognosis. So we check the levels of circulating microRNAs in PCOS patients and some control patients. And we found some diabetogenic microRNAs are really overexpressed in PCOS patients. And these microRNAs could be involved in the pathogenesis of pathophysiology of PCOS, especially related to their chronic anovulation. So that's what we think very interesting. And we also try to establish a prediction model. We check the baseline microRNAs in these patients, and we found that we can predict whether they can recover their menstruation after metformin treatment based on their microRNA levels with a not bad predictive value. And we think this could really give us a hint that microRNA can be a tool to predict the therapeutic response of metformin. As for other medications, there are some treatments that with less evidence according to the guidelines. The guidelines told us that some anti-obesity medications such as GLP-1 agonist, very popular. This could be considered, especially for those women with excess weight. And another popular, I say nutrition, or this is not a medicine, it's a kind of a nutrition supply. Inositol, this also can be considered to treat PCOS patients. It can reduce the hyperandrogenism and also improve their ovulation. So here's a brief summary here. Firstly, we mentioned about the diagnosis, still need to fulfill the Rotterdam criteria. And now AMH level can be part of the diagnostic algorithm to the diagnosis. And also we mentioned about the pathophysiology. We try to use iPS cells as a disease modeling tool. We differentiate the cells into vessel cells, ovarian cells, and we think this is really a good tools to investigate tissue-specific disease mechanisms. And for treatment, should be symptom-tailored, individualized, and we try to find out that microRNAs might be a good prediction tool for the therapeutic response. So that's it. Many things, many studies we're still working on, and we really hope we can have more interesting outcomes to share in the future. Thank you.
Thanks so much, Chu-Chun. That was really spectacular. It was a wonderful way of just a very practical clinical overview of PCOS, diagnostic criteria, which no matter how many times we review them, it is always helpful to review them again, and, very practical approach to treatment, but then this
Yeah.
incredibly exciting and novel tool. What made you even think of using like pluripotent stem cells induced to try to study PCOS? I mean, it's an incredible model because, I never really thought about it, but we don't have an animal model.
Oh,
And so what a great idea. What made you think of
thank
it?
you. I have a last slide. Sorry, I forgot
Oh,
to mention that. I
wonderful.
want to make a acknowledgement.
But, there are a lot of researchers and fellows and trainees on the Zoom, and I think it's always, when someone has a really novel approach to a common disease, it's kind of exciting to hear what made you think of that and get involved in that model.
Thank you. Yes, we think iPS cells has a really good potential to, especially for PCOS that we cannot get many tissues from these patients. And yes, we try to do that to find more, yes, maybe probably a better or new models to study this disease.
Now, did you have a mentor who was using pluripotent stem cells in another disease model, or was already starting to look at this cell as a model for PCOS, or was it kind of you just thought of it yourself? I think it's great for trainees to kind of hear how a researcher,
Oh.
a clinical researcher, can get involved in such a fascinating basic science approach to a very common clinical disease.
Yeah. Yeah,
PhD helps. Most clinical researchers don't have that, but
thank you for mentioning that. Like the names shown here, our professors, Professor Ho, Professor Chen, they're all they did iPS research in the past, and we also have other professors try to establish iPS cells and differentiate into all size, although this is there's still a long way to go, but they really discovered the potential of stem cells, and so that's why we started to use the iPS cells in the research of PCOS. But
and
yeah,
was it your
so
idea to kind of focus on endothelial cells? It seems like a really interesting cell type to kind of study in PCOS.
thank you.
Great. Oh, Erin, question for you, please.
Thank you so much. That was fabulous. I'm a clinician. I'm not a researcher. And my question was more, with the prevalence up to 10%, as you indicated, I find patients are really, really worried about their fertility when they get this diagnosis. So I know you alluded to the return of ovulation after metformin, but how do you counsel patients to sort of assuage their fears that they're really going to have a problem with infertility? Because it's a lot of times we diagnose this, they go right to the internet and read all about the infertility.
Well, that's a really important question. Thanks for mentioning that. For those patients who seek fertility, well, the most efficient way is to give them that ovulation induction medications like clomiphene or aromatase inhibitors. Usually I will encourage them, I tell them, okay, you're not ovarian failure, so you still have very high chance to get pregnant after medication, although you might need some help. But I think one more bigger problem is how to keep them healthy during the pregnancy. We know there are extremely high risks, not extremely, but 2 to 4 risks of diabetes or hypertension during pregnancy. So it is quite important to encourage them to establish a healthy lifestyle, I think, to maintain this during the pregnancy. But I would tell them it's not very difficult for you to get pregnant by medications sometimes.
Great. If anyone else has any questions or comments, feel free to raise your hand, unmute. I looked in the chat, didn't see too much, but I kind of have the same approach you do, Chu-Chun. I try to reassure these patients, Erin, I say, you are our most fertile, infertile patients, meaning you have great eggs, you just don't ovulate them. But Chu-Chun, I was so glad you brought up what I think is really one of the most exciting new novel changes in the diagnostic criteria. and this may even be new for our fellows, several of whom are on the call, that we can now use AMH in certain situations, as you said, as a marker for the PCO morphology. And I think this is really important. You know, there's a lot of, you know, for those of us doing research with actual people, and we're reproductive endocrinologists, we do a lot of ultrasounds, it doesn't seem so important. But, you know, so much important PCOS research is epidemiologic, right? And you can't do ultrasounds on 1,000 women or even 250 women cost effectively. So I know that some of the epidemiologists I work with who are looking at PCOS in their studies are thrilled to now have this relatively inexpensive biomarker.
Yes, I think
part of
this
the
really
criteria.
something very interesting and something new in the updated guidelines. So I like what I want to mention it here. Yes, especially I heard that ultrasound is really expensive and not that easy accessible in United States. So it would be
You just
much
have to come
easier.
in. It's vaginal. It's usually a little uncomfortable. And then there's a lot of
Yes.
variability in the assessment, you know, in the
Yes.
person reading it. So it's kind of exciting. Now, of course, as you mentioned, the problem is AMH has so much
Yes.
variability in the assay. And it's fascinating that they said we can use AMH as criteria, but didn't give us a cut
Yes.
point, right? What
Yes,
AMH level should we be using? So I think that will certainly develop over time as more people start to use AMH as criteria. But I think that will help move PCOS research forward, you know, when people are doing large studies in populations, and also in the third world where you don't have the same resources we may have in Taiwan or the US for, you know, bringing women in and doing ultrasounds. That's really expensive. So I think that's a nice change in the criteria.
Yes, me too.
Anyways, well, let's see. Hello. How could it be if I am out of the country to send a message? I'm not quite sure what that means. You could certainly put a question in the chat and we would bring that up. This is from, let's see, Aylin Catherine Palmera. I think if you're out of the country and would like to send a message, the chat works very well. We would certainly address your question from the chat. Erin, you have something else to share.
Yeah, I just wanted to say how much I enjoyed this, and I have the honor of taping my Klibanski Scholarship talk to Taiwan OB/GYN Society after this, actually at 1 o'clock today. So you set the bar very high for me, and I just wanted to thank you because I really enjoyed this.
It's really spectacular, Dr. Huang. So thank you so
much.
Thanks so much to the Klibanski Scholars organizers for, you know, having this incredible opportunity for junior faculty to make these international connections, to present their research across the world. And of course, mostly to you, Dr. Huang, for being up at 1 a.m. now to share your really exciting research. And I think I won't be at ASRM this year, but our two fellows on the session will be. And so hopefully you'll get to meet some of our reproductive endocrinologist faculty and fellows when you're at the conference, if you're coming this year. It'll be great.
Of course. I wish I can visit in the future. Thank you.
Terrific. And yes, good luck to Erin as she tapes her international presentation. It is quite a hard mark.
Okay.
That you have set for us today.
Yeah, thank you so much for the arrangement. I'm really honored.
Thanks so much. And thanks for everyone for coming and learning with us today. Really appreciate it. Take care. Bye-bye.
Thank you. Thank you. Bye-bye.